Damija, can you start?
Now, just let the people join. Wait for 1 minute. I will start the session. Just wait.
Abhishek, just confirming you can hear me talking.
This
Yes,
is
we
some
can hear
echo
you,
coming.
but you will have to keep one of your device off.
The echo is still coming.
Now,
Speak a sentence.
can you hear me now?
Yeah, it's
Better.
better. It's better.
All right. So, Asmita, we are live now.
Yes, sir.
Perfect. Good morning, good afternoon, good evening to everybody, whosoever in this globe. I once again welcome you all in year 2025, and I wish you all a wonderful, happy new year. As the president of AOSNR, I continue to bring you the series which we started in May 24, and we are now into the ninth session. So it is the ninth month. Every Thursday of the month, the first Thursday of the month at 3 o'clock Indian Standard Time, we are running this webinar. And from various topics which we covered, from introduction to neuroplasticity to innovation in assistive technology, cognitive rehab, physical therapy, occupation therapy, speech and language rehab, psychosocial aspect, we come to the nutritional consideration and neurological rehabilitation. We have chosen the speakers very carefully from different part of the Asia, and I'm pretty sure that this topic, which is something not been heard very often in the neuro rehab congresses and not been talked regularly while we're dealing with the rehabilitation. So this will interest to many of you, and I'm sure you will be taking out the many new points from these esteemed speakers. Also, we will continue to have next webinar, which will be on 6th of February. I must tell you that in each of our webinar, 28 to 30 countries and nearly 200 people are live, and more than 100 people are on YouTube watching this webinar. So these are some of the popular webinars. We continue to do that. Our first part, last session, would be on 6th February, which will be patient-centered approach and success stories. So I would welcome you if anybody has some very, very interesting case with success story, is most welcome to send me the case on email, and we will definitely try and select and include a couple of cases from you all. And also, if you wish to have some patient who would like to present the interesting part of his story, he's welcome. Kindly recommend and let me know that it's possible. Please do it in next 1 week to 10 days. To take over today's webinar, I have two esteemed personality here. One is past president of World Federation of Neuro Rehab, Professor Stephanie Clark from Switzerland, and she has always been very supportive to India and the Asia, and she is very much here. Welcome you, madam, to the ninth series of AOSNR webinar. The other gentleman is very well known in the health sector of country India. He is chairman of the Brain Task Force by government today, and he is the chairman of IBAS, one of the Institute of Mental Health and Rehabilitation in Delhi. He is also the chair of special interest group on movement disorder. Most important thing is the most active member of IFNR and into the task force. So I welcome you, Professor Rajendra Damija, on this ninth session of USNR webinar. Over to you both for the taking over the session. Thank you very much. And I once again welcome you all and have a wonderful 2025 to all of you.
Thank you, Professor Nirmal Surya, for introducing us. And A very happy New Year to all of you, and it's good to see Professor Stephanie Clark once again. And we have had a lot of interactions in the recent past, and I'm glad that Professor Nirmal Surya had chosen her as a co-chairperson and a eminent speakers for this very important yet neglected aspect of neurorehabilitation, role of nutrition and diet. Neurorehabilitation, as you know, is a multidisciplinary aspect of recovery, and diet and nutrition plays a very important role. And I'm sure that the speakers would highlight the various aspects. Whether it is stroke recovery, or it is TBI, or it is neurodegenerative disorders, or it is other neurological disorders where we actively go for neurorehabilitation, the diet has very important role in addition to the therapy. And that's where we have to add on, and we have the speakers who are going to speak on this aspect very soon. So I will just leave it here and ask my co-chairperson, Professor Stephanie Clark. It's always a privilege and honor to have you and we speak on the same platform where Professor Stephanie Clark is there. So over to you, Professor Clark.
Thank you very much, and thank you very much for this request to chair this wonderful, very interesting session. Well, Happy New Year to all of you, first of all. And I hope that this year will accompany you in a personal and professional life in the very right way. Now, the topic of today is highly interesting, as was said before, and we need to learn more about it. Now, we need also to apply critical thinking to all the research which has been done, so that we can apply the right things for our patients. I would like to pass the word to those who will introduce the speaker personally.
Rajendra, you can do the introduction.
So our first speaker is Professor Chamara B. Jayatunga. He is consultant in rehabilitation medicine and currently works in rheumatology and rehabilitation hospital in Ragama, Sri Lanka. He is trained in UK and he's lots of achievements, but particularly as a specialty doctor in rehab in NHS hospital in UK. And he's got number of credentials and very renowned expert in the rehab field. So over to you, Dr. Chamara Jayatunga.
Thank you very much for the kind introduction. And can you all hear me?
Yes.
Okay. And give me a second to share my slides. And meanwhile, I should wish you all a very happy 2025. Are the slides clearly visible?
Yes, sir.
Right. So the topic that I'm going to talk about is the importance of nutrition in supporting neurological recovery. And the outline will be, first I will give a brief introduction on how the nutritional status and the neurological conditions are linked. And then I will briefly highlight to give an understanding of the multiple mechanisms these nutritional impairments can contribute to the overall disability in a patient with a neurological diagnosis, and also how to assess nutritional status in the rehab setting, and also some key steps of addressing the problem. So nutritional status can be affected in both acute conditions like stroke, TBI, as well as in chronic neurological conditions like advanced dementia and advanced Parkinson's disease. There's so many trials available demonstrating the high prevalence rate of both types of conditions, from acute to chronic neurological conditions. So the prevalence ranges from, depending on the assessment tool and the diagnostic criteria, it ranges from 1.95 to 60% in stroke, And there are studies showing it from 36.5 to 90% in chronic conditions like dementia. So there's an interesting relationship between nutritional status and the neurological condition. I see it as an interrelated relationship. Common impairments that we see in neurological conditions themselves can result in nutritional impairments. For example, chewing and swallowing impairments, neuropsychiatric manifestations, and cognitive impairments. And also, the neurological conditions can increase energy demand, especially in hypertonic conditions. So these mechanisms or these impairments can cause neurological issues in the patients. On the other hand, impaired nutrition itself can prolong the morbidity and mortality in neurological disorders. So it's a two-way process. So I would like to suggest this five-step approach to a patient with any disability, be it nutrition, be it weakness, be it balance. So this is the five-step approach that I generally use, which is we're going to identify the disability, and we are going to do assessments, and then goal planning, outcome measures, and treatment or the intervention. So step one would be to identify the disability or the problem. So in this case, it will be the nutrition. And there are so many models describing how to identify problems in the rehab setting. And I personally prefer the WHO ICF model, which has 5 main domains. And we'll see by how we can use this model to identify problems related to nutrition, which will help us to plan our interventions. So the problem will be impaired nutrition in a neurological condition, be it acute or chronic condition. So what are the affected body structures and functions? So again, the two interrelated factors. First one will be the contributing impairments, symptoms or signs of neurological condition contributing to impaired nutrition. So dysphagia, increased energy demand, spasticity, dystonia, frequent spasms, neuropsychiatric manifestations, very common. Mood disorders, they have direct relationship with food intake, catatonic behavior, sometimes in severe traumatic brain injuries we see, and then eating disorders. In addition, there will be cognitive impairments and constipation, very common, which can have an effect on the nutrition by reducing the food intake. Then we'll see how the impaired nutrition itself can cause ongoing neurological problems. So one common mechanism would be electrolyte and micronutrient deficiencies. For example, if there is deficiencies in potassium, calcium, magnesium, there will be muscle weakness, contributing, in addition to the primary neurological diagnosis. So if the problem is in the limb muscles, there will be problems in transferring mobility. And if the problem is in the chest muscles, there will be problems in secretion clearance and postural balance problems. As well as when the postural muscles are affected, there will be postural dizziness. And these nutrition problems can affect or worsen the neuropathy. And of course, it can affect cognition as well as the general weakness can affect the swallowing function itself. So these are all interrelated. In addition, I would like to highlight potential complications of impaired nutrition. Because of the lack of mobility, there will be reduced joint range of motion, contracture formation, falls risk, poor tolerance to infections, and the last one. We should all keep that in mind as clinicians working in rehab settings. There can be refeeding syndrome, and that has to be kept in mind when we plan our interventions. So we all know because of these impairments, there will be activity limitations in ADLs as well as basic ADLs as well as instrumental ADLs. And then of course, there will be participation of restriction. And then the WHO model says these disability or the problem depends on the social circumstances as well as the financial circumstances. as the environmental factors. Then comes to the personal factors. Very important to take detailed history and get information from past records and get the picture with all these 5 domains that will greatly help the rehab team to set goals. So what are the personal factors? Age, of course, and then very important, the other medical comorbidities. There can be history of diabetes, pressure ulcers. There can be recent admissions to ICU, needing ventilation, renal impairments, liver impairments, past cancer treatment. Most of these, we all have patients undergoing rehab following cancer treatment, so very common to have nutritional issues. And then, of course, ongoing sepsis. Then a thorough medication review is needed because certain medications can cause severe loss of appetite, changes in taste sensation, and then dry mouth and reflux as well. Then we need to assess the pre-morbid fitness, the lifestyle, food habits. For example, some of our patients with communication impairments might be having special diets like gluten-free diet. So this information have to be obtained carefully. Of course, then coping styles, education, profession, this social history, and also the insight and the understanding of the condition by the family, friends, and relatives. Right. So now we try to identify the problem. Now we need to do detailed assessments to define the extent of the problem. So again, as I mentioned, detailed history, and then we need to define the baseline nutritional level. And then we have to do, depending on that, a nutritional assessment, and it has several components. So I've listed out the common components of the nutritional assessment. One would be the data on regarding the current food intake. It could be food diary, recalls if the patient has the cognitive ability to recall the amount of food intake, and then food frequency questionnaires for appropriate patient cohorts. And then we'll be doing anthropometric measurements, clinical examinations, and of course, laboratory imaging studies. So what are the anthropometric measurements? So the simple measurements like height, weight, and BMI. And actually, rather than the current weight, if we can get an idea about whether there's a recent weight loss or what's the ratio of the patient's current weight to the ideal or usual body weight, will be more beneficial in rehab goal setting. But we have to be cautious for patients who are having severe edema and in trained sports personnel because they have bigger muscle mass. Sometimes we can't get the exact height because the patient can't be mobilized in rehab settings. So then there are these nomograms available, but we have to make sure that these are validated for the population of that person belongs to, because these ulnar lengths and knee heel lengths, sometimes we might not be able to directly correlate between certain ethnic groups. So in general, if an adult loses more than 5% of his or her body weight within a month, or like 10% in 6 months, that's more in chronic patients, an overall assessment of nutrition is required. And keep in mind that if there's a rapid weight loss within several days, that could be possibility of severe dehydration. Assessment of body composition is also important, and because with prolonged with prolonged periods of reduced mobility or due to paralysis, there will be changes in body composition in the fat and the muscle masses. So there are so many ways to do it. The bedside assessments using tricep skin fall thickness, mid-arm circumferences, they're generally easy and practicable to do in PC rehab wards. But if you need further information, there are certain tests that we can request, like bioelectrical impedance tests, as well as the gold standard, which is the DEXA scan. But for these, we might need the inputs of a specialist. Now we'll come to the clinical assessments. Most of things can be done as rehab clinicians. So we need to check the general appearance. And then there are so many clinical signs of micronutrient deficiency. Especially, I would like to suggest to look for signs in skin, hair, nail, and tongue. And then there are clinical signs of adipose tissue loss. So generally they can be seen over the eye rims, upper arm, rib cage, and over the ilium. And then there are certain areas in the body which indicate significant muscle loss. So the suggested areas would be the temporal regions of the face, over the scapular region, dorsum of the hand, knee, and the thigh and the calf. But we have to keep in mind that certain lower motor type neurological diseases, which are wasting sort of conditions, can cause muscle wasting. So we have to do the overall assessment and come to the conclusion. And of course, we need to pay attention to the dentition as well as a swallowing assessment. There are laboratory tests which can guide the nutritional assessment. One is the proper assessment would be for protein balance, or the nitrogen balance will be to get a 24-hour full protein intake and to correlate with the 24-hour urine excretion for the nitrogen. But since it's cumbersome, especially in rehab patients, so we might have to go for other kind of auxiliary sort of parameters. So one commonly used blood test for nutrition is the visceral protein, which is albumin. But we have to keep in mind again that albumin is an acute phase protein. So in certain infections, the albumin can be low. So we have to correlate it with the CRP. And for the micronutrient wise, we can check easily the blood potassium level, calcium, magnesium, phosphate, and zinc. Magnesium, phosphate, and potassium, they are very important, especially if the patient is chronically in chronic malnutrition, because we have to avoid developing refeeding syndrome. So it's better to check the electrolytes before starting the intensive nutritional rehab. Of course, we can check serum vitamin B12 level, D level, and folate level, and start replacement if indicated. So this chart shows common clinical signs in micronutrient and vitamin deficiencies, which are available in all these common textbooks. Right. So by now we did the clinical assessment, and then now we'll have to come to the diagnosis of malnutrition. So there are these well-established guidelines published by these international bodies. I've just listed out 3, and they use these parameters that I mentioned in the clinical assessment. So we can come to a diagnosis whether it's a mild, moderate, or severe malnutrition. And then we can, at the bedside, we can do nutritional screening as well. So there are so many nutritional screening tests available. One of the commonly used one is the MUST score, which is generally validated for hospitalized adults. And it again categorizes the patients to low, medium, and high risk for malnutrition. And medium to high risk generally would require referral to a specialist and detailed assessments and planning the nutrition. Right. So we identified the problem, and then we did detailed assessments to kind of define it. Now we need to do the goal setting as we do in rehab settings. So an essential component. So we can use the same principle for nutritional goals as well. So this again has to be individualized, and we can set short-term, long-term goals, and then with the help of the nutrition specialist if available, and of course after discussing with the patient and the next of kin. After setting the goal, we need to select an outcome measure, and again there are so many outcome measures available, so we can select something relevant and practicable. So for example, one of the commonest outcome measures is the BMI. So we can say, for example, if the BMI is, let's say, 15 to begin with, after a certain set of interventions, we are going to achieve BMI of 18. Again, the target, it all depends on those factors I mentioned earlier. Change in body composition is again a commonly used outcome measure. That is the muscle mass versus the adipose mass, waist circumference rate. And also, sometimes we can use functional outcome measures. But if you use a functional outcome measure, we have to make sure that there are no other contributory factors into it other than the impaired nutrition. For example, we can take pressure ulcer healing, improvements in balance as a functional measure of improving the nutrition. Step 5, the rehab interventions or the nutritional interventions. Again, for simple patients, simple cases, we can get the input of the medical and the nutritionist and come up with a plan. But in complex patients, especially most of the patients who are undergoing inpatient rehab, we might have to get the help of the rehab MDT. So, because each member will have a role. Let me explain. So sometimes these patients might be, for example, might be on stomas. Sometimes they undergo complex plastic surgical interventions for severe pressure ulcers. So we might need inputs of the surgeon to correct certain nutritional defects that we see in stoma patients. Sometimes we need a neurologist to check the diagnosis and see whether there's any lower motor type neurological component to explain the severe wasting that we see. And then we need the nutritionist, of course, for specialist inputs to calculate the diet plan. And then physios, how can they help? Some of these patients that we see have impaired head control. So the patient can't chew and swallow. So, for example, achieving head control and balance with the help of the physio will overall contribute to improve the nutritional status. So is the occupational therapist. They can do the assessments and help with props and prompting. So to help and use assistive devices to help with feeding and feeding so that the dietary intake will improve. Speech and language therapists will have a big role if there is a significant oropharyngeal dysphagia present to help increase the nutritional intake. In certain mental health conditions, which is very common in patients with neurological conditions, the mental health support team will play a big role. Could be counselor, could be psychologist, maybe a psychiatrist, depending on the availability. We have to get them on board, especially if we are treating a complex patient. And then social service officer, if available, will help to get the available funding and social services so that the dietary and the nutrition optimization can happen quickly. So it's a MDT work, and of course, patient and the family in the center. So that brings to the end of the presentation, and the take-home messages will be: neurological patients, it is important to identify nutritional deterioration at an early stage. The reason being, nutrition can be interrelated in two ways. Sometimes certain neurological impairments can worsen the nutrition, and the nutrition impairment can worsen the neurological condition. And you know that certain neurological disorders, the rehabilitation is time-taking, it's expensive, and it needs a lot of resources. So if we can identify the contributory nutritional components and correct them quickly, it might help to improve overall functional outcomes. Thank you very much for your attention.
Thank you, Dr. Jayatunga. This was comprehensive review of assessment and outcomes and goals, and you covered everything as far as the nutritional component of a multidisciplinary neurorehabilitation team is concerned. So I'm told that we'll take the questions at the end. It is very important to have this holistic view and a very, very relevant approach with well-rounded and culturally adaptive diets. And that's very crucial component of optimizing nutritional assessment and building up nutrition in the patients who are undergoing neurorehabilitation. So I'll request Professor Stephanie Clark to introduce the next speaker, Professor Parit from Thailand. Over to you, Professor Stephanie.
Damija, second talk is by Bhakti.
Next is Bhakti Samant.
So I don't see the, okay. Well, our next speaker is Mrs. Bhakti Samant, Chief Dietitian at the hospital in Mumbai. She has the very high qualifications in the field, and she holds a numerous very prestigious positions in the field of nutrition. I'm very much looking forward to this part of the seminar, and thank you very much for your presentation.
Thank you. Thank you for the introduction. I'll just quickly share my slides. My slides are visible. Yeah.
Yes, ma'am.
Yes, okay. So thank you, the doctor who just presented on the nutritional assessment was very comprehensive. You've set a nice, background for my presentation. My talk will cover the dietary guidelines for individuals with neurological disease. The time given to me is 25 minutes and the topic is very vast. I hope I'm able to do justice to the topic allotted to me, because when we are talking about neurological diseases, we are talking about a wide spectrum from acute to chronic. It can be infectious, vascular, or trauma disease, or it can be a degenerative disease like dementia, Alzheimer's, Parkinson's. So, very important to talk about nutrition for these patients is because they almost cover 15% of any acute care hospital inpatient area. You'll find at least 30% of rehab centers, 30% of these patients in certain rehab centers in inpatient, and almost 50% might be in nursing homes or even at home care. And I think Dr. Chumara has very nicely explained why malnutrition is one of a very a nutritional risk for, there are multiple nutritional risks when we talk about neurological patients, and malnutrition can actually increase the mortality as well as even decrease the efficacy of the rehab process, and hence it is very important to identify early. I'll dwell a little bit in detail because before I go on to the MNT, that is a medical nutrition therapy, it's very important to understand the challenges that we face while we are doing, our medical nutrition therapy. So there are multiple factors when we talk of malnutrition in neurological disease. One is decreased intake. Now, this decreased intake is directly associated to the degree of dysphagia. So, if there is presence of dysphagia, definitely it is going to cause an impact in the intake of the patient. There are a lot of GI dysfunctions that we observe in these patients: nausea, vomiting, delayed gastric emptying, constipation, which can also have an impact on the overall intake of the patient or even the tolerance to food, and hence the risk for malnutrition. And another very, very important factor to understand is the disturbance in the energy expenditure. So when I say energy expenditure disturbance, what do I exactly mean? There is an alteration in the estimated energy expenditure for the patients depending on the different symptoms that you will observe. So like if a patient is having tremors or dyskinesia, these are the patients who are going to have an increase in the energy expenditure. So automatically their requirements also increases. When we are talking about patients having, say, a loss of lean body mass will definitely reduce the estimated, energy expenditure, but refeeding syndrome, presence of refeeding itself is going to increase the energy expenditure. When we talk of the physical activity, patients undergoing rehab, they have an increased energy expenditure, and hence it is going to be directly associated to an increased requirement in the energy demands. Patients having a respiratory failure, infection is directly associated to an increase in the energy expenditure. So it's very important to understand what is the condition that you are seeing or the patient is presented with, and based on that, whether there is an increase or a decrease in the energy expenditure, because that is what is going to determine my total energy goals which I'm going to set for the patient. When we talk of neurological diseases, there are a lot of drugs which are also going to cause nutrition related side effects. Like, for example, interferon, which might cause weight loss, anorexia, depression. There are certain antipsychotic drugs which can directly lead to weight gain or central obesity. Levodopa, we all know that there are multiple side effects associated with it. There can be constipation, vomiting, nausea. In case of steroids, then definitely there is going to be a decrease in the muscle mass, and anticholinergic drugs, which can cause dry mouth or dehydration or delayed gastric emptying or constipation. So important to understand the type of drugs or the medication that the patient is on, because maybe not the neurological disease, but it is the drug related treatment also which can hamper the nutrition related side effects, and which is what is going to also bring about micronutrient deficiencies. So when we talk about micronutrient deficiencies, specifically if the patient is on steroids, and I know that there is going to be a negative calcium balance, there are high risk of osteoporosis. Levodopa, apart from causing B6, B12 deficiency, it also leads to hyponatremia in patients. So it is important to identify these, because it's not just the condition but the medication which is what is going to impact the MNT. In case of diuretics, there is thiamine deficiency or antacids. Long-term antacid use can also cause phosphate deficiency. So important to understand certain drugs, go a little more detail in terms of the drugs and try and understand the food-drug interaction, which is going to impact the side effects, which is directly associated to a direct correlation with malnutrition. So yeah, talking about dysphagia, very, very important, because it can have a lot of serious complications, which is going to impair the prognosis of the patient. So dysphagia is nothing but there is also a decrease in deglutition efficacy as well as safety. So when we're talking about a decrease in deglutition efficacy, it is going to impact the intake of nutrients and fluids. So definitely malnutrition and dehydration. And when there is a safety related issue, obviously these patients are at a high risk if the precautions are not taken for choking, for aspiration. It can cause pneumonia as well as respiratory failure. So as a dietitian, we work, as a clinical nutritionist, we work very closely with our speech therapist when we are dealing with patients with dysphagia, because they might be either only on enteral or a transition from enteral to oral or a combination of both. So in such cases, very important to work very closely with the speech therapist, because they are the ones who give us the guideline in terms of the exact consistency or the right consistency of the meals to be provided, and based on that we do our menu planning for the patient. When I'm talking about my risk for pneumonia aspiration pneumonia, we know that it is malnutrition. Dysphagia is directly associated to causing malnutrition, altered immunity, muscle dysfunction, which again aggravates the risk for aspiration pneumonia. So very important to identify, and most of it are interrelated. So to understand this is very important, and a timely reference for these patients is very, very important, because not all patients will have the same degree of dysphagia and not all will have the same kind of MNT. So yeah, when we're talking about nutrition support for stroke patients, so yes, very nicely explained by doctor about screening and assessment. Important to identify, because based on the malnourishment status, whether the patient is well nourished or not well nourished is where I need to aggravate my nutrition therapy. When it is a patient who is, say, not malnourished to start with, but is having dysphagia, definitely here then we need to look at the changes in the food texture, and a failure to have the modified food, textured food. Eventually the patient is going to land up in enteral nutrition mode of feeding, whether it can be a peg or it can be a rice stew, and it all depends. So the feeding mode or the type of feeding will depend on how long the patient is going to be dependent on the enteral support. So very important to identify that patients who are malnourished but are not dysphagic, for them even addition of an oral nutrition support, oral nutrition supplement in the diet, supportive along with the the home food, can definitely help to improve the status. Yeah. So now I'll move on to my dietary interventions because we've seen what challenges, the major challenges that we have, and the interventions are going to be all based on the stage of the disease. So when I'm talking about nutrition support in a chronic neurodegenerative case, again, whether it is a preclinical phase or a early disease or an advanced disease, the symptoms that I'm seeing in the patient or the state, the overall metabolic state of the patient is where the MNT would be directed to. Obviously, in case of disturbance of appetite, there is an energy homeostasis due to neurometabolic changes, there are pathologic changes happening, there are metabolic changes happening, as well as there can be some genetic factors here. The disturbances of attention width, definitely here we need to look at a decrease in the energy intake. So to identify the overall, so here the food recall really makes a very important role here to understand how much I need to add on in terms of supportive therapy for these patients. And sometimes it can simply just there can be an inappropriate choice of food that the patient has, which needs a correction to achieve their macronutrient compositions or macronutrient requirements in the diet. There's an increased energy requirement which can be due to the secondary disease, behavioral disturbances, or we have seen certain other symptoms which can actually increase the energy requirement of the patient. And there can be a low energy intake which can be due to the need of care, there can be dysphagia, there can be pharmacological sedation. So all these things needs to be considered when we are planning the nutrition therapy. So when we're talking about nutrition therapy for these patients, most of them are going to have a neurorehabilitation program which they'll be a part of, and that itself is going to lead to a lot of metabolic changes. And there is an increase in the demand for calorie needs, especially if there is muscle wasting or there's a significant physical therapy. For example, a brain injury patient, the energy expenditure may increase significantly during the acute phase, necessitating the need for a higher calorie intake. And similarly, there can be a patient with multiple sclerosis or Parkinson's disease, which has a lot of involuntary movements like tremors or spasticity, which itself can increase the energy demands. So that is the reason the guidelines, if you look at the guidelines for patients having a neurological disorder, depending on the disease, the symptoms, as well as the stage of treatment that they are on, or the therapy that they are on, the calorie range would anywhere be between 25 to 35 calories per kg body weight, which is very, very important. In some cases of severe malnutrition or very high calorie demands, we do go more than 35 as well, but that is with extreme caution and under supervision. When I'm talking about my protein needs, again, very, very critical, because muscle repair, recovery, especially in patients who have undergone stroke, TBI, or having a neurological deterioration, very important to consider that part. Immune function to prevent infection or enhance wound healing in case of surgeries. Protein intake should be sufficient, because that is what is the main, and yeah, not just the protein, it's also the protein to the calorie ratio, and hence higher protein should always match with the calorie requirement of the patient. So here my requirement would vary anywhere between 1.2 to 2 grams of protein per kg body weight per day, depending whether my goal is of maintenance or a recovery or rehab. So it will be all dependent on the stage of the therapy. And this is definitely for patients who are not having any kind of a renal involvement. In case if there is a renal involvement, then definitely it is dealt in a different manner. And it's very important that we distribute this protein throughout the day. It cannot be given as just one or two, high protein meals, but divided across the day. And sometimes we have to do a step up therapy for these patients. That is, we cannot start directly with a higher protein. We always start with, say, 0.8 to 1 to 1.2, and then gradually step up as the need demands. And when we talk about the micronutrient support, again here, it is obviously one first most important thing is that to identify if there are any deficiencies. And micronutrient supplementation is definitely initiated only when we know that there are some defined deficiencies which are there. But like we saw in the food-drug interaction, there are certain medications which are having an impact on the micronutrient absorption or causing deficiencies, and hence supplementation majorly of vitamin B12 or folate, which is very important. Vitamin D, again, because that supports brain health, may also assist in recovery from brain injuries. Magnesium in selected patients might really help to improve the nerve function or muscle relaxation. Iron, particularly important in case if there are patients who have undergone or had a massive blood loss or having anemia issues. Antioxidants, again, antioxidants can be provided naturally through the diet itself, but there are times where they are on special diets or restricted diets is where you might have to, supplement even in terms of supplementation. Omega-3, a very potent antioxidant, is proven to have anti-inflammatory neuroprotective effects, which has helped in brain function as well as recovery. So, and these are fats which are crucial. So even when the patients are on enteral feeds, combinations of different types of fats can definitely help in the patient recovery and support. And gut health plays a very important role. Like we saw a lot of drug nutrient interactions, we saw a lot of side effects associated with the medication, which directly affects the gut. And we know that if the gut is not functioning well, that itself is going to be one more trigger for malnutrition to start. So probiotic, fiber supplementation, if not possible orally, then through enterally, there are different types of fiber supplements available which are added in the patient feeds to supplement them with their fiber requirements to maintain a good gut health. So it is very important to not neglect fiber and its probiotic effect. When we talk about stroke patients, now, like all the time, I've been talking and focusing about the different stages of the disease, whether I'm looking at an acute stage, whether I'm looking at a subacute stage or a chronic stage, depending on the stage where you are, targeting your care, your goals will vary. Obviously, in my acute stage, my first goal is to prevent malnutrition, to prevent dehydration, to manage in case there is dysphagia, and also in case of an aspiration risk. So very important. And here is where your assessment criteria comes in. So assessment goes by default, whichever stage that I am seeing the patient, the assessment is going to be the first defining element for my MNT. And in such cases where there's a presence of dysphagia, like we saw in our previous flow as well, that when there is a presence of dysphagia, definitely doing enteral feeding is the best way to meet up with the nutritional requirement of the patient. And if it is a long term, if I have a patient who I know is going to require enteral support for more than a month, then we look at gastrostomies as our next line of treatment. So here your monitoring of electrolytes is very, very important. And in some cases where we know there is a risk for dehydration or where we know there is a electrolyte imbalance, additional supplementation is much helpful. And even in our post-stroke phase, the energy demands are really high. So maybe you start off with a 1 gram protein per kg body weight, but you gradually need to go up to say 1.5 grams and more than maybe 25 calories per kg body weight for non-obese patients. So again, here the anthropometric assessment of the patient is going to define whether I need to go with 25 calories or more than 25 calories, or to go with higher protein and lower calories. So it all depends on my nutritional assessment and my nutritional diagnosis for the patient. In chronic stages, we are yes, here this is where we are going to look at promoting the cardiovascular health or managing the other comorbidities, and this can also be a phase where the patient is also on a transitional diet or a combination diet of oral feeding along with enteral feeding, or oral with a gastrostomy feed. So managing the diets in a transition manner is very important, because all of this is eventually going to help us to improve the quality of life for that patient. And when I'm looking at even a patient with TBI, whether it is an acute, subacute, or a chronic stage, my goals are going to be different. And so if I'm looking at an acute stage patient, here there's hypermetabolism that I have to address. So when I know there is hypermetabolism, it is going to come with catabolism. To prevent malnutrition and fluid imbalance, very, very important. And in such cases, the resting energy expenditure might go up to even 140 to 180 times of the normal reading. So here it's very important to identify that. And even my protein requirements can go very high from 1.5 to 2. And in case of morbidly obese individuals, we might go even higher on protein, but a little low on calories. In a subacute phase, where I'm here trying to support mainly the cognitive and the physical recovery, or to prevent any secondary complications, there can be a transition of my diet from enteral to oral. So here the different consistency of the foods can be tried, but again, we don't do any trial and error. As a nutritionist, I would always rely on my speech therapist or my swallowing therapist to give me a proper indication of the consistency of the meals for me to do a prescription. There have been studies that neuroprotective nutrients like the omega-3, because of its antioxidant and anti-inflammatory effect, can be beneficial in these patients. And when I'm looking at a chronic stage or a post-injury, more than 6 weeks post-injury, here my goal is to enhance the long-term neurological recovery, to manage the comorbidities, maintain the quality of life. And again, here in this case, anti-inflammatory diets can help to support these patients. So the issues and recommendations for nutrition therapy in patients with TBI. Now, here one of the major issues that comes in. So yeah, we are aware that there is a hypermetabolism. We are aware that the patient is in a hypercatabolic state, and there is an increased morbidity or weight loss. But what is limiting us is to identify the exact requirement for the patient, because as per the gold standards, we are supposed to use an indirect calorimetry, and majority of the best of the centers don't have an indirect calorimetry, and hence we are relying more on the weight-based calculations. And one of the drawbacks in reality is also that the weight check for these patients are also not being done regularly, and hence it is mandated that at least on a weekly basis we monitor the weight, because that's the only way of directly trying to understand whether whatever nutrition that you're providing to the patient is enough or not. So it is important to have that weekly weight monitoring for these patients, because as a clinical nutritionist, my entire therapy or my MNT is all dependent on the weight of the patient. When I'm looking at other issues with these patients, it is delayed gastric emptying, or there can also be an intolerance to the enteral nutrition that we have provided. So these are also to be looked into. Proper positioning or continuous infusion or a motility promoting agents can be used, which can help in improving the tolerance to enteral nutrition. And here, obviously, we are looking at energy dense formulas where I get more energy than the overall volume that I'm supplying to the patient. Sorry. The routes and timing of access in patients who are unable to maintain a volitional intake, where EN versus PN. I mean, we need to consider that. So obviously, early enteral nutrition is what we are looking at in such patients, where you want to initiate enteral nutrition as early as between 24 to 48 hours. And we can use a supplemental PN if we are not able to meet up with our energy requirements of more than 60% of the target. So again, going back to the same point of assessment, based on the assessment, I set my goals and my targets, and then I do a follow-up in terms of the intervention that we are providing, and we look at the tolerance. And when we look at the tolerances, where we are able to decide on whether we want to continue only with EN or you want to go with supplemental PN. So that is very important to look at. Glycemic control also here we need to consider in these patients. And a patient admitted in an ICU, we can go up to at least 180 milligrams per DL of sugar, which can, blood sugars, which can be a target. And protein support is very, very important here. And in some cases, we might have to go up to even 2 grams per kg body weight. So again, this is something which is very difficult to deliver, because your tolerance is also going to come into play. And that is the reason there are different ways in which we would want to, feed the patient. So a quick check on the etiology for weight loss and dietary related interventions in patients with multiple sclerosis. Again, here, depending on the cause of the problem that you're dealing with, my intervention would change. Whether it is reduced mobility or fatigue, disability, whether there is a physical difficulty in manipulating food or fluid, because here is where I would modify the type of the meals that I would, give to the patient. In case of a poor sight or maybe quickly fatigued when eating, then again, your small frequent meals or adding a dietary supplement would be an ideal way to deal with. When we know there is poor appetite, or there is a reduced cognition, or there is dysphagia, so here not only the portion but also my texture of the food has to be modified. And in such cases, we might have to depend on high-fat dairy foods or energy-dense foods for these patients while we are planning the meals for them. And last but not the least, when we are talking about ALS patients, again here, assessment, and then it comes to the clinical assessment, where the doctors would take a call on whether to put PEG or not. And here, whether it's a low risk or a moderate risk, but a PEG feed is any day better tolerated than giving an but if in case if there is an advanced stage here, then in that case we would just go by the oral intake as per tolerance, or just giving a palliative care. So now, as we are talking about a lot about enteral nutrition, there are certain enteral feeding considerations while we are going to deal with neurological patients. So here, the level of consciousness of the patient, the ability to swallow thickened liquids or soft foods, risk of aspiration, duration expected for the need of enteral feed, the nutrient demands of the patient, as well as, very important, the patient and the family's desire with regard to nutritional treatment. These all needs to be taken into a consideration before we move to an enteral feeding for the patient. Now, there are different routes of enteral feeding. When we are talking about, it can be nasogastric, it can be gastrostomy, it can be nasojejunal. But in most of these patients where we know that the requirement or the support, the enteral support is going to be required for more than a month, then obviously gastrostomy tubes work better in these cases rather than putting a nasogastric tube. There are different feeding methods which can be used, whether if you want to use a bolus feeding, intermittent, cyclic, or a continuous. So when I say a bolus feeding, it is that you give a specific amount of the feed at one go. And you have a specific interval, like a 2-hourly feed or a 3-hourly feed. When we are talking about intermittent feeding, again, it is spaced between 4 to 6 hours of feeding, but the feeding window is not 5 minutes. It would be that the feed is administered over a period of 20 to 60 minutes. And then again, a break. When we talk of cyclic feeding, so there can be within the 24 hours, there are a specific time of or specific hours of the day where we are giving the feeding, and there are few hours where we completely stop feeding. And then comes the continuous feeding mode, where it is given in a drip-wise manner. So again, my continuous drip feeding method would come into play when I have patients with EN intolerance, because I know that the patient is not tolerating bolus. I will have to do a continuous drip for the patient to at least improve the tolerance. Once the tolerance is better, we then can move on to a bolus feeding. So there are different ways in which feeding can be modified. Yes, if you go as per standards, a continuous drip feed is what is recommended. But yes, we do have patients, and we have to understand, because these patients are going to have therapies, there are going to be rehabs, there are going to be a lot of breaks in between the sessions. So it's important that the feeding has to be adjusted based on the other treatment modalities. Now, what do we feed with? So ideally, especially when the patients are in a hospital, and we know when they are for a short term or where we are just introducing enteral feeds, there are different formulations available. We provide with complete scientific formula. It can be a standard polymeric formula. It can be a oligomeric, or what we call it as a semi-elemental formula, which is pre-digested, or it can be a special disease-specific formula. So based on the mode as well as the site of enteral feed is where we would decide on the type of formula. And then also comes in another aspect is the tolerance of the patient. That is also one of the criteria which we have to consider before I'm going to select an enteral formula. And then comes our blenderized feed. So we do have, and we know that neurological patients in rehab or having a neurological disorder might be dependent on enteral feeding for a very long time, or rather they will be on home enteral feeds maybe forever. So in such cases, cost effectiveness is something that we need to consider. So though we have complete scientific formula in our hospital, but when we have patients who are getting discharged on home care, are going to be on home enteral nutrition, we do transition them on blenderized feeds, which can be more cost effective, and because they are more whole natural foods that we are providing to them, it is beneficial, and to some extent even socially as well as psychologically, it is making the patient feel that he's eating the home food, and even for the caregiver, where they feel that we are feeding our food to the patient. So I think that is one thing to be considered very strongly. But yes, there are certain contraindications where I would not want to give blenderized feeds, where there are immunocompromised patients, or when the tube which is being put in the franchise is very small. In case I want a patient to be on a continuous drip feed, then blenderized feeds will not be my ideal go-to formula. When I have fluid restriction, that is where is the maximum challenge. So when we have fluid restrictions, we don't go, on blenderized feeds. We would purely give scientific formula, because here I'm able to give maximum in the minimum fluid volume that I have. In case if there are multiple food allergies, again, there we would not want to give blenderized feeds, because it's very difficult to control if you're not aware about which particular foods are actually, having an allergic response. And one very important note of caution is that it's very difficult to achieve standardization when we are doing blenderized feed. So I have certain calculations on paper, which will be calculated as per certain grammage of foods that I'm giving. But what the patient or the relative are actually making and giving to the patient, there is a very big gap. So here the counseling part comes into play, giving them exact proportions, exact dilutions of how to make and have a standard feeding method. I think in that case, when the patient as well as the relatives understand that, and they understand the importance of these volumes and portions given, then definitely blenderized feeds can be considered, because we have to look at the cost effectiveness over a period of time. So that is where I would give. And overall, if you are going to look at the entire spectrum of interventions, everything is directed towards malnutrition, whether whether you're looking at the medications of the patient, you need to look at whether they are on any restricted diets or not, the energy density of the meals, enrichment of the meals with proteins, fats, carbohydrate. Some might just simply require support with food shopping. Some might require support with meal preparation. Some might just require company while eating, a pleasant mealtime atmosphere. There are different ways in which you can promote food and fluid intake, access to foods 24/7, having energy dense snacks available with them to be eaten in different, in meal frequencies. Education of the relative is very, very important. Education regarding the oral nutrition supplements is very, very important. Texture modified foods, finger foods, helping with eating, subcutaneous fluids to overcome a crisis situation, tube feeding to overcome a crisis situation, or a parenteral nutrition. So there are different interventions which can be used to prevent malnutrition in these patients. So your assessment is the key. There is no other way to decide on how you actually need to help the patient. And in conclusion, the role of nutrition in neurological disease is absolutely very, very vital, not just for tissue repair, immune function, to have a good energy metabolism, as well as for cognitive recovery. And it is significant, it can significantly improve in patients undergoing rehabilitation, because here your outcome is going to all depend on the nutritional status of the patient. Individualized approach, like I said, we looked at different modalities, we looked at different treatment therapies. So your individualized approach is the most important for the patient, and a multidisciplinary team. I alone cannot do any magic with the patient. I need the swallowing therapist, I need my clinician, I need the support of the entire team, the caregiver, the family, all of them. So a multidisciplinary approach is the most important, for doing any kind of therapy for these patients. So thank you so much. With that, I end my presentation.
Thank you very much for this, for both talks, which were comprehensive, which gave us a fantastic overview of the complexity of the field, but also the complexity of the practical applications. I have questions which I don't see questions online, and I would like to start with a question.
There's one more talk. There's one more talk.
One more talk.
I'm sorry, I missed the program. Terrible.
No problem.
My apologies. Probably I should introduce, because Professor Damila is just offline. Our next speaker is Dr. Parit Bongaet. He is board member of the Royal College of Physiatrists in Thailand, and a member of the board of Thai Rehabilitation Medicine Association. He has many professional functions, and he serves as invited lecturer of the Department of Physical Medicine and Rehabilitation at the Ramadipodi Hospital, Mahidol University. He has many very important areas of interest, and received recommendations for his work, several recommendations for his work. I'm very much looking forward to your presentation. Up to you.
Hello. I took the liberty to change to New Year, 2024 to 2025. The talk today is about ketogenic diet. I have a disclaimer to make. I make and sell robotic device and gait analysis device in Thailand. And if you can't remember my name, you think of Parrot, Dr. Parrot, and I'm Parit. I'm not as professional as the other former two speakers in terms of nutrition. I received little background training in nutrition as an MD, but I've had a lot of metabolic problem because of my eating, and I have reversed that with ketogenic diet, and it start my interest in this topic a couple of years ago. Now this talk will be about first what is ketogenic diet, what are the types of it, and how ketones has the function in physiology and in neurological diseases, and a quick look at the evidences that are available. What the ketogenic diet is the diet that raise up level of ketone bodies in the body, and in human body this consists of these three things: acetone, acetic acid, and hydroxybutyric acid, which BHB, the beta hydroxybutyric acid, is the main one. And it's about 4 times of acetic acid. And when people say they measure ketone bodies, they mainly measure beta hydroxybutyric acid. And the unit used is usually in millimole per liters. What they call nutritional ketosis is when the diet can raise up ketone body or BHB beyond 0.5 and more. And this is not the same condition as ketoacidosis or diabetic ketoacidosis, because it's totally different. The only similarity is the rising of ketosis, but ketone body in the body, but other physiology is totally different. Since 1920, doctors have used ketogenic diet and fasting to treat epilepsy. In the beginning, they ask patient to fast, and they find that fasting patient have less seizure and they have higher ketone body, body in the blood. Later, they find ways to induce the rising of ketone in the blood with diet and not fasting. And more recently, a supplement is induced instead of changing the diet. In the last 10 or 20 years, ketogenic diet has regained interest for treatment of many health conditions like metabolic syndrome, obesity, and also health condition. The ketone is in the blood. It comes from the conversion, mostly in the liver, conversion of free fatty acid and the middle chain fatty acid. And the level of this fatty acid depends on the level of carbohydrate ingested and the duration of fasting and supplementation of middle chain fatty acid in the supplement liquid form. There are 3 types of ketogenic diet. The first one is caloric restriction or fasting. The second one is the classic ketogenic diet, which consists of 4:1 fat per protein in terms of weight. And when you have 4:1 fat to other macronutrients, because fat is more calorie dense than in classic ketogenic diet, you have 90% fat calories, fat as calories. And there's the thing called ketogenic diet mimetics, means usually drinks that contain ketone salt and middle chain triglyceride and middle chain fatty acid. The key to ketosis, the key to nutritional ketosis is low insulin, and low insulin level can be the result of low carbohydrate diet and maybe in combination with fasting or the long duration of not eating. The low level of insulin increase the conversion of free fatty acid to ketone bodies. I want to say that in normal people, in people who have functioning pancreas, which can secrete insulin and which has no extremely severe insulin resistance, they always have the possibility of self-correcting mechanism in which the ketone body cannot elevate out of hand. For example, over the night we have dawn phenomenon when we don't eat for many hours, and then the counter-regulatory hormone like glucagon and noradrenaline and catecholamine would trigger gluconeogenesis, and the increasing level of sugar will reduce down ketone production because it will increase insulin, for example. It is known that ketone in the serum is correlated with decreased or lower level of inflammation and anabolic in skeletal muscle and lipolysis. But it also has oxidative stress reduction and neuroprotection effect. It seems like that the oxidative stress and excitotoxicity goes hand in hand. They trigger each other and both leads to apoptosis. In neurological disease like brain ischemia and especially during reperfusion injury, there's increased free radical production from the mitochondria, and that is known to extend the penumbra zone damage. In animal experiment, it is shown that ketogenic diet, whether before the injury or after the injury started, can reduce free radical production, reduce oxidative stress, and increase the free radical scavenging capacity. So it reduced mitochondrial damage and it reduced the vicious cycle. Another thing is that is a bad thing that happened in after brain ischemia or brain insult in other form is the excitotoxicity. Usually, this started from a failure of energy metabolism. This will lead to accumulation of glutamate and glutamate receptor activation, which cascade into calcium, which leads to calcium accumulation, and this leads to further neurotoxic mechanism, which in the end impair mitochondrial function. So it's again a vicious cycle. You have ischemia, you have brain insult, and the mitochondria is in energy crisis, and it's producing free radical, and it's caused a damaging thing, which damage itself further. And all of that leads to the stimulation of apoptotic protein, which start the apoptosis. Now look at some of the evidence. In acute brain insult, there are animal, which I mean the rodent, the rat, mouse or rat study. It is shown that there's consistently a reduction of brain edema, reduction of apoptosis, and improved cerebral metabolism, improved behavioral outcome, less paralysis or better cognition after in the group of animal that is that receive ketogenic diet and receive experimental TBI than those who did not have received ketogenic diet. But there's limited study in human. There's some control trial, but this happened in 19 something, in the late 90s. What they found is that in both of the papers that I have came across, that I have found, there's no data on clinical outcome. The clinical outcome was not discussed. It's like a feasibility study whether ketosis can be achieved safely, and it can. But ketosis cannot be achieved if sugar is in the feeding. What about stroke? In rodent experimental model, they consistently found that ketogenic diet reduced brain edema, reduced lesion volume, and it did not change or did not help with cell viability, but it reduced the lesion volume. And the animal shows improved behavioral outcome. This is true whether you start ketogenic diet before, days or weeks before stroke, or right after stroke. But in human, I found one study. They use classical 4-to-1 ketogenic diet. I forgot to tell you that there are other modification of ketogenic diet. They are all low carb and high fat, but the ratio may be a bit different, and they have different names. The human trial I mentioned here consists of 6 experimental ketogenic diet patient and 11 control of mixed stroke type. They can achieve ketosis. On average, the ketogenic diet group patient have average 1.1 millimole per liter of ketone, but only 3 out of 6 have the BHB level higher than 1.5 millimole per liters. They think this is due to hidden carbohydrates in the thickened up resource, thickened up because they are that are modified maltodextrin and modified starch in there, and modest level, even small level of carbohydrate in the food can block the production of ketone, but it's feasible and it's safe. There's no side effect, but the clinical outcome is not different. Now let's quickly look at neurodegenerative disease. It is now popular to say Alzheimer's disease is type 3 diabetes because of 3 reasons. First, there's impaired insulin signaling in the brain. The same way as insulin signaling is impaired in insulin resistance in other part of the body of the people with type 2 diabetes. And other pathophysiological mechanism is found, which is similar. This again, oxidative stress, inflammation, and mitochondrial dysfunction. We see this in metabolic syndrome, and we see this in type 2 diabetes, and we see this in Alzheimer's disease, but in the brain. And the collection of amyloid beta. So Alzheimer's disease study in animal, they use this. Some study use sleep-deprived mice, and some study use mice with special genetic. They found that the cognitive function of those Alzheimer model animal is improved, and even they see reduction of amyloid plaque and reduction of neuroinflammation. So it's very interesting. But in human, there are many studies, and in a review, it shows that most of the papers show improved cognition, memory, and executive function, but and they don't seem to be a trend where mild or more severe cognitively impaired patient benefit from this. This is the picture, the page from that review. These are randomized control trial, ketogenic diet with versus placebo or control. And the population range from mild cognitive impairment to moderate Alzheimer or dementia. And the benefit is mostly in cognition. What about Parkinsonism, another kind of common neurodegeneration? In this study, they found that the UPDRS total score has declined in experimental case series, but the mood score, the depression, anxiety score has improved, and the metabolic parameters like triglyceride, HDL, even inflammatory parameters like the CRP. All improve. In ALS, there's one case report of a male patient, 64 years old, who started ketogenic diet 9 months since after the onset, and he refused standard treatment, and that is the kind of modified ketogenic diet this patient is taking. Still mostly fat, 60% fat by weight, and less than 5% net carb. 2 meals a day and no calorie counting. With this measurement of ALSFRS, the total score seemed to stabilize over the course of 18 months. That's good. That's better than the average progression of ALS. So that's what's make but some decrease in the salivation and dyspnea score, and the physical functioning is clearly getting worse. The speed of walking and stair climbing is clearly worse, but it's not worse. So it's very interesting. So, but there's a word of caution, because some papers say that ALS progression may not be linear, may be faster in the beginning and slower in the middle and fast again in the late phase. So in this case, the seemingly slow progression, maybe because the patient is entering the middle phase, I don't know. But it's just interesting and nice thing to share. In terms of mood disorder, there's 2 main putative mechanisms which ketogenic diet might help. On one side is the energy consumption, because ketone bodies are alternative fuel to the brain, especially when the brain gets used to ketone. It can use a large percentage of energy from ketone. So when you have more energy, the brain could function better. And in terms of neurotransmitter, we already see that ketogenic reduce glutamate. And the review say it increased GABAergic transmission, and it has some effect on the monoamine, but it's not clear how it affects the monoamine. That's one interesting case series I would like to share from French. 31 refractory depression case were admitted. They receive 3 meals a day and their usual dose of antidepressant medicines, which failed to help before. And 23 patients were lost. They refused the treatment after they started it for a while. But 27 of the remaining, all of them improved. All of the remaining patients improved. And up about 40%, 12 from the remaining 27 has reached score 1 from this CGI. This is, and I show the rating here. This 1 is normal. 1 is complete remission. It's quite dramatic. This is how much they can reduce the medicine. So, after my quick review, I have found that ketogenic diet seems to be feasible and safe in neurological patients. It could potentially help with brain energies, which fits with my personal experience as a people eating keto. And the results seem to work better in terms of mood and depression, as we see in the depression and also in Parkinson, and less well in other function domain. Even though there's a lot of supporting evidence in animal study, we have not yet seen a human study that shows positive, strong positive result in after stroke or after TBI or other disease. I have my speculation I would like to share. Maybe because a lot of people is is not having a very healthy mitochondria. Even when they are not sick, they are not eating well, and their mitochondria are already half sick. So it may be too late to help them with ketogenic diet. So I really look forward to see if there are study that it would be hard to design, I think, but to see the protective effect of people who have been eating ketogenic before the brain insult, that might help, or a longer term study, I don't know. Do I have a few minutes left, or do I run out of my time?
You can.
2 minutes. Good.
Yeah.
The brain is a network. If you look at this picture of deep neural network, AI, it consists of processing unit which receive information from other processing unit and send out its computation to other processing unit. It's a very complex network. The human brain is not different. 60% of the weight of the brain is white matter. It's that much connection we have in the brain. And the connection costs a lot of energy. You can see that human rank highest than other animal. The brain weight like 2% of our body weight. It consumes 20% of the energy. So it's a very energy hawking part. And in Alzheimer, you know, amyloid plaque like to be found. It's usually more common to be found in the association area, which is the hub of the network. It's the regional hub of the brain network. So there's good reason to think that Alzheimer has something to do with energy production or problem with energy brain production. I think that the brain is a network and there's no fixed center. That's why the brain can adapt and we can train it. Network is important, but I think it's more important to understand the modules of cognition, neuropsychological modules, because we cannot touch the network, but we can test it with functional modules point of view. And for that reason, I get a lot of requests from my student, so I write a handbook, and I would like to share the first chapter of it for those who are interested, and also if you're kind enough to give me comments so I can improve it. So that's all I have to say. Thank you very much.
Thank you. Thank you very much for this very interesting talk. Very intriguing. I suppose we can now start asking questions. Is that correct?
Yes, ma'am.
I don't see any questions in the chat or questions and reply boxes. Well, I would like to start with a finally general question, which is to all the three speakers. You have outlined the detailed analysis of few fields. It's very complex. There are no simple solutions, either for the dietary prescriptions, for the situation of different patients, nor the specific diets. But then on the other hand, there are things which you need to look for as single patients, like what should I privilege? Is it increasing his resistance, getting back into shape, or when should I start reducing the risk factors by the appropriate diet? How do you deal with it in the practice? And how do you communicate to the patients? It is at each stage you need to talk to them, to explain to them the specific goal of what you are doing. How do you adapt the very high level sophistication of the scientific underpinning what you are doing, and how do you communicate it? Who would like to start with? Yes.
May I try?
Samant.
First of all, I always make sure that the patient and their family is the one making decision. The rehab team is like a coach. So our job is to simplify things and show them options. What are the possibilities? For example, in people with progressive neurological disease and also advanced elderly people, some of them don't want the feeding tube at all. But they have to know the risk involved. They have to know that feeding too much, too often, they can have aspiration, and if their immune is not good enough, they can have pneumonia and sepsis, and that can be fatal. I think our job is to simplify things so that they can have a meaningful, informed consent.
There are a couple of questions has come, Professor Stephanie. The one is from Intense Sabrina from Malaysia. Which diet do you prescribe for your TBI patient? Anybody who wants to reply on this? Dr. Chamira.
Yeah, it is talking about which diet. Now, if it's an oral diet versus what is a enteral feed, so depending on the mode of feeding, if it is an oral diet, then to meet up with the increased requirements, we would add ONS, that is an oral nutrition supplement. If this patient is on an enteral feed, so when we are starting off in our institute, at least we are providing with a complete scientific formula through the enteral feeds, and we try and give them a combination of whatever formula that we are giving along with fiber and certain micronutrients is what is given. So there are different patient as per the need that we would modify the type of meals that we are giving.
The question here is diet for the TBI. So would you like to comment, Dr. Parit? Traumatic brain injury.
I don't have the strong background to add anything now.
Dr. Chamira, you have anything to add on to that?
My answer would be, I mean, we have to individualize the diet. I don't think there's one set of diet that we can generally recommend. So I would go with individual, case by case approach.
Perfect. I think, frankly speaking, there is no specific diet for the brain injury to improve the brain. I think one need to look at overall, nutrition of a patient after the injury, depending on how bad or how easy he has been. So that's the thing. But Bhakti, for you, the question is, any guideline for amount of protein intake based on serum and levels?
Okay, so we don't look at serum albumin levels as a malnutrition indicator or for defining the protein requirement. Definitely, we want it to be within the normal ranges, but we don't use the albumin as the indicator to decide on the protein. It is the diagnosis and the need of the patient on which we will, give the protein requirement and not the albumin levels. So, yeah, I think.
Thank you. Dr. Parit, for you, another question from Bejanyam. He is asking, how about the ketogenic diet if the patient has high uric acid?
Wow. There are people treating gouty arthritis with ketogenic diet. I have no direct experience, but I've listened to their rationale, and it seems interesting. I'm not practicing in that field, so I have no clinical experience at all. I think
But I
that
suppose your uric acid must have been the normal when you started. Your uric acid level must have been the normal when you started your diet.
Mine? Yes, yes.
I think this is a technical question, Bhakti.
Just,
If you have
can
answer,
I
you can
just
get.
add one point to it? Sir, can I just add one point regarding the ketogenic diet? So, if ketogenic diet, even if it's a classical KD, if being practiced with all the right steps and with the right amount of protein, you normally don't see hyperuricemia. But yes, there are patients who might be at a risk of developing stones. So for them, portrait is added in their, if they are at a risk or with close monitoring. But if done with all the right steps, with right monitoring of the urine ketones, with the type of good fats in the diet, you normally don't see a very high uric acid levels.
Honestly, I have a couple of patients on ketogenic diet with epilepsy, and we even don't look at the uric acid level when we are starting the diet. So I suppose it may be just a myth. If patient tolerate the ketogenic diet, that is the biggest question. Out of 10, 8 people just walk away. It is only the 1 or 2 who accept this. So that's the biggest challenge than any other challenge. I think Gamal Ali has again one question for you. How about the clinical nutrition on neuroplasticity? Since you presented a couple of data on neuroplasticity, would you like to comment on that?
So again, no specific, guideline as such. Okay, you follow this therapy for neuroplasticity, but definitely we will focus a little bit on the micronutrient content, omega-3 fatty acids, and antioxidants in the diet. If needed, even in the form of supplementation to be given to these patients, especially for that, but nothing like a written guideline which says that if a patient is having neuroplasticity, then these are the guidelines to follow in terms of clinical nutrition. There are no written guidelines. It is only understanding the situation and focusing on antioxidants and obviously along with protein, antioxidants and micronutrients.
I just want to add is good, healthy diet is the key for good brain health. So whether you are talking of plasticity or anything else, I think brain health is brain health. And one of the point between the 7 point is a healthy diet beside your exercise and all. So these are important. There's another question. The dietary recommendation are individualized and also depends on the level of training given during rehab. Dr. Chamira, you would like to comment?
Could you please repeat the question?
I understand the dietary recommendation are individualized and also depend on the level of training given during rehabilitation.
I mean, training to the
Therapy,
carers.
as therapy increases, the patient is lying down, go to the mobilization, go to the further robotic. You need to obviously make the changes in the diet with calories.
Yes, yes. So it depends on the factors which were mentioned: the energy requirement, the posture, the patient's and protein requirement. So it's a dynamic process. So in the MDT, maybe once in 2 to 3 weeks at least, depending on the patient's progress, we might have to change the prescription.
So now the question is, Intan is asking, is quite a question come from Gita. Do you prescribe the sattvic diet? So for the neuroplasticity enhancement, Bhakti, would you like to comment sattvic diet? Say a few words about sattvic diet to the people who may not be aware about what is sattvic diet.
Okay, so when we're talking about sattvic diet is mainly just the natural foods with vegetarian proteins and grains and not providing any animal foods, along with it. But I think like even sir mentioned before, there is nothing on a prescription given from our end as sattvic diet. We are more focused on a balanced diet, and to meet up for those requirements, we might have to incorporate all the food groups necessary in the diet. So in my practice, I have not done only a sattvic diet at all for any of my patients.
Thank you. I think that there are a lot of questions pouring in now. Are recommended amount of protein intake for people with neurological disorder are more as compared to that of the healthy individual? Anybody want
Yes.
to answer?
So for a healthy individual, the RDA says that our RDA for Indians is anywhere between 0.8 to 1 gram of protein per kg body weight. And this might vary depending on the type of physical activity that one is doing. But for a sedentary individual, it's 0.8 to 1. Whereas for a neurological disorder patient, the protein requirements would start from 1.2 and above, depending on the stage and the condition and the requirements. So there is a difference.
Perfect. I think there's another question from Sheila Peter. How does the non-invasive brain stimulation on pharyngeal motor cortex enhances the neuroplastic-like effect along with dietary modulation to nutrition therapy? What could be the possibilities? I think the nutritionist has to answer on this. Could you understand the question, Bhakti?
No, sir, I'm sorry, I did not get it.
So, basically it is the TCDS, which is, current stimulation into the brain. So she is trying to tell that that can be comparable with, nutritional therapy, making these changes. I think that's too remote. Electric stimulation, you are modulating the brain itself. By diet, you are not modulating the brain. Diet is a one principal factor to provide the energy to the brain, which are all add-on thing, which help the patient get the balanced nutrition and calories. So I think they cannot change completely to the neuroplasticity, but they could be add-on. Dr. Parith, is ketogenic diet can improve the insulin signal in the brain in Alzheimer's disease or type 3 diabetes? How is the recommendation? Is any other diet recommended? How about Mediterranean diet? This is a big question for you, Parith.
Can you repeat the question, please?
I think the best you answer is ketogenic diet can improve insulin signal in the brain in Alzheimer's disease or type 3 diabetes?
Wow. I cannot speak with authority, but as a physician, and from from the little information I have, I think it's very possible that it can be helpful. And I'm counting days. I'm waiting to see more evidence so that I can safely apply this in my clinic. If I have a family member, a relative with Alzheimer's disease, or even a beginning MCI, I would really like to try this because I don't see the damage. But I cannot speak so scientifically.
I completely agree.
I just can share my point of view like that.
I think this is a very complex question, needs a lot of answer from the research, and we apologize, Jimmy, to you that we won't be able to give you an exact answer. Bhakti, could you answer how about Mediterranean diet? Any idea about that?
Yes. So yeah, one of the drawbacks with ketogenic diet, though there are studies promising where it helps to improve the insulin resistance because it's a very low carbohydrate diet. So it does have a benefit there. But the major drawback with ketogenic diet is the compliance. So at least in our Indian setup, the compliance where we don't have majorly non-vegetarian eating population. Even the non-vegetarians are mainly vegetarians and non-vegetarians on very selective days. So that is one of the challenges when it comes to ketogenic diets. The major factor is compliance, because today when Dr. Parith is talking about evidence, you just not need evidence in terms of few cases, but a lot of cases. So a number of cases that we are looking at. So that is one of the challenges. And apart from that, yes, a Mediterranean diet would be a better way of dealing in neurological cases, because it's talking about good fats, moderate fats in the diet. It's talking about incorporating fiber containing complex carbohydrate in the diet, good quality proteins in the diet, with omega-3 and your all the antioxidants in the diet. So definitely Mediterranean diets have a promising effect when it comes to neurological disorders, or in such cases there are evidences, especially even with insulin resistance.
I thank everybody. There may be few more questions, but I think we are already overshoot by half an hour. So we apologize now. And I want to thank the chairperson, both Professor Stephanie as well as Professor Dhamija, and to all the three speakers, Bhakti, Dr. Chamira, and Dr. Parit, who has been very actively involved in the question answer session. Initially, we felt that there was no question, but suddenly we had. In case one or two questions are there, we will send it to Bhakti, who would email and reply to you on that. I want to request Abhishek to kindly give vote of thanks and close the thing.
On a very diverse topic of nutritional aspects in neuro rehab, and we are able to cover why it's important, how to assess, how to plan, how to execute, and also new evidence on ketogenic diet. It was a wonderful session, a lot of learning for all of us. Thank you very much. Thank you.
Thank you. Bye-bye.
And the
Thank
next,
you. Goodbye.
The next session will be on 6th of February, same 3 p.m. IST. Topic theme is patient-centered approaches and success stories. If you have some success stories, please email it to IFNRCon to include them in the next session. Thank you very much.
thank you.
Thank
Thank
you.
you, everybody, and have a wonderful
Goodbye.
year.
Thank you. Bye-bye.
Thank you.